Good morning, everybody. I would like to announce the starting of our session of 2035 Asian Cardiovascular Clinical Research Seminar. And today we have a few prominent speakers from Asian countries. And this seminar, our seminar, will be devoting to arterial hypertension. And the first speaker of our session is Alina Kerimkulova from Kyrgyzstan. Alina Kerimkulova. And also I have the second, our moderator, Yi Zhang from Shanghai, from China. He will be chairing this session along with me. And I would like to say hello to Professor Yi Zhang and for our participants. And I will announce our two first speakers, and Professor Yi Zhang, you can just present the third and the fourth speakers. So we can start, and our first presenter is Alina Kerimkulova from Kyrgyzstan. Her topic is management of resistant hypertension. Alina, stage is yours. Please, you are welcome.
Can I start now?
Yes, I think you can start to use the full screen.
Good morning, dear colleagues. And today it's very pleasure to take part in this great scientific event. There is no conflict of the interests. And today we should encourage decreasing of the level of the blood pressure, because high blood pressure, you know that it is very heavy, it is having very great bad outcomes for patients. And in the recent clinical publication, you can see results of that decreasing of level of the blood pressure can be beneficial for patients, because it leads to decreasing of the risk of the dementia. And also there were reduction of the 23% of myocardial infarction, and 33% for stroke, and the 42% of the heart failure, and decreasing of the cardiovascular deaths less than 30%, and decreasing of the up to 15% of all causes of the mortality. Therefore, nowadays it's very important to maintain normal level of the blood pressure. But what about the patients with the resistant hypertension? Unfortunately, resistant hypertension patients, they are having increased risk of the bad outcomes. According to the recent clinical guidelines from European Society of Cardiology, the definition of the resistant hypertension includes conditions is when the level of the blood pressure is elevated more than target level, and also this condition, it is typical for patients who are always receiving at least 3 and more antihypertensive medications. One of which is diuretic. And also above mentioned conditions should be confirmed by the instrumental test like ambulatory blood pressure monitoring. We should also remember about the conditions which could lead to development of the high blood pressure resistant hypertension. But these causes include above mentioned causes, that here poor adherence and persistent with the treatment. That's why before the diagnosis and confirmation of resistant hypertension, practical doctors should exclude above mentioned causes of pseudo-resistant hypertension. It means that diagnostical workup must include checking exclusion of the primary aldosteronism, renovascular hypertension, obstructive sleep apnea, etc. So that's why secondary hypertension is common in resistant hypertension. It's it was confirmed by the clinical studies. And exclusion of the pseudo-resistant hypertension, it's very important because according statistical data, up to 50% of patients with resistant hypertension may actually be due to pseudo-resistance. Hence, a rigorous reassessment of patients is critical. What about the management of resistant hypertension? In patients with resistant hypertension, management should include above-mentioned possible causes of resistant hypertension, including behavioral factors, using of medications for and undetected secondary causes. That's why lifestyle interventions like above-mentioned factors, they have been confirmed in the well-known TRIUMPH clinical trial. And it's important to identify and reverse contributing lifestyle factors. As you can see, lifestyle interventions like in the TRIUMPH trial include management of obesity, specific prescription recommendation of the specific diet, DASH diet or Mediterranean diet, recommendations for constriction of the sodium consumption, and of course, alcohol moderation and smoking cessation. And as an example of above-mentioned non-pharmacological management, we can observe in the clinical trial, which has been included in the Cochrane database systematic review. It has been confirmed that weight loss diet decreases blood pressure among patients with a hypertension, and these are evidence of above-mentioned results. But non-pharmacological management, of course, it would not be enough, and that's why pharmacological approach is very important. According to recent European Society Cardiology recommendations, adding of mineral corticoid receptor antagonists, spironolactone should be considered as a fourth step. And initially, first we use inhibitors of the renin-angiotensin system, plus with combination with calcium channel blockers, with combination with thiazide diuretics, and spironolactone should be considered as the fourth step. And for resistant hypertension management, it's also highly recommended to monitoring of specific tests, as you can see at this slide, and practical management should be, of course, patient-tailored with attention to tolerability of the medications, because tolerability of medications is very great factor for better adherence and better compliance for therapy. Unfortunately, patients with pharmacological therapy, sometimes they're having increased levels of blood pressure despite of using above-mentioned pharmacological medications. Therefore, nowadays, in the recent clinical guidelines, it has been included non-pharmacological management like device-based therapy of the resistant hypertension. And renal sympathetic denervation is now supported by the leading medical professional associations as an option in selected cases with evidence from recent randomized clinical trials. Of course, this device-based therapy cannot be considered as a routine procedure, and it is not, of course, first choice decision, but it can be helpful in patients with resistant hypertension. So the algorithm of management of patients with resistant hypertension as was recommended in the clinical guidelines, recent clinical guidelines, is presented here, and the diagnosis after confirmed and after diagnosis, we should use specific medications step by step, and after using above mentioned medications, if blood pressure remains uncontrolled, we can consider using of the device-based management, renal sympathetic denervation. But this decision should be, for this decision, the patient's decision should be also included. Patient also take part in the final decision. Patient preferences also should be considered. So, and I would like to report one case report. 29-year-old man, he was admitted to hospital after having some infection, but his level of the blood pressure was very high, to more than 200, systolical and diastolical more than 100. By the way, patient was non-smoker. He refused using the alcohol or specific recreational drugs. He was not smoker. He doesn't consume alcohol. Also, we exclude the using of the specific medications like non-steroid anti-inflammatory drugs or beta mimetics was excluded. As admission time, his blood pressure was 100, but body mass index was increased. This patient has undergone the investigation of the coronary angiography, and the coronary spasm was not increased, was not confirmed. The secondary hypertension was excluded, like sleep apnea syndrome or pheochromocytoma was also excluded. And this patient, he has already received 5 groups of medications. First, AC inhibitor. Second, calcium channel blocker, amlodipine. Number 3, diuretic, indapamide. Number 4, beta blocker, bisoprolol. Number 5, spironolactone, but due to gender, male gender, the spironolactone was substituted by the eplerenone. So this patient finally he has been taking 5 medications. In spite of taking all 5 medications, his level of the blood pressure was remaining about approximately 160 systolical and 95 diastolical. After counseling with doctor's team and using the patient's relatives, the renal denervation was recommended to that patient. He gave written informed consent, and after renal denervation, his level of the blood pressure was decreased up to 120 systolical, but after renal denervation, he was still taking 2 medications. First, beta blocker bisoprolol, and second medication, it was perindopril, 10 mg per day. So this example of case report with patient with resistant hypertension. So let's make conclusion. Resistant hypertension nowadays it's remain high prevalent, high risk, and unfortunately often misclassified clinical problem. And the hypertension patients with resistant hypertension are exposed to associated serious complications with high morbidity and high mortality. Diagnosis of patient with resistant hypertension requires confirmation and, of course, exclusion of the secondary causes. And adding of the spironolactone can be as a fourth drug. In some patients, adding in different devices to control blood pressure should be included in the management of the hypertension, for instance, renal denervation. And individualized treatment is important, engaging of patients in decisions. Thank you very much.
Thank you, Dr. Alina. It was very interesting presentation. So I think we'll leave the questions and discussion to the end of the session. So now we can move further. And the next presentation goes to Rano Alieva, which she will talk about remodeling of the cardiovascular system in arterial hypertension, modern diagnostic capabilities. Please go ahead.
Good morning. Is it okay? Could everyone listen to me?
Yes, we can hear you.
Oh, thank you. So, good morning, dear professors, colleagues, doctors. My name is Kim Andrei, and I'm a doctoral student at the Republican Specialized Science and Practical Medical Center of Cardiology. And before the beginning, I should say that Rana Alieva extends her sincere apologizes for not being able to attend in person due to unforeseen circumstances. So instead of her, I will present our topic on theme remodeling of the cardiovascular system in hypertension, modern diagnostic capabilities. First of all, it is necessary to talk about the prevalence of cardiovascular disorders, especially in Asia. By 2050, the prevalence of cardiovascular disorders will reach 729 millions, and the top three cardiovascular disorders will be: the first is ischemic heart disease, second the peripheral artery disease, and stroke. And the estimated overall mortality rate could increase by 90%. So, but there is one question: but why will all this happen? The cause of everything will be the risk factors, uncontrolled risk factors, in particular components of the metabolic syndrome. And the projected cardiovascular mortality is expected to rise significantly in Central and Southeast Asia by 2050, and mainly due to the high body mass index, elevated glucose level, and kidney dysfunction. And in contrast, high-income Asia-Pacific shows declining trends, reflecting better risk factors control. However, let's get back to the present. And in nowadays, arterial hypertension continues to be a single most important modifiable risk factor, being responsible for the high burden of cardiovascular morbidity and mortality. Let's check some statistical data about hypertension. Arterial hypertension causes more than 10 million deaths annually worldwide. In Europe, arterial hypertension affects more than 150 million people, with a prevalence of 30 to 45 in adults and age adjusted rates of 24% in men and 20% in women. And according to a joint study by the World Health Organization and Imperial College London, the number of adults with arterial hypertension has doubled over the past 30 years, from 650 million up to 1.3 billion. And nearly half of those affected patients were unaware of their condition. And this represents the largest analysis of blood pressure data, covering 184 countries between approximately 30 years. And let's some check about the arterial hypertension mechanism. All of us know about the stress and excessive sodium intake, the genetic determinants, and obesity lead to peripheral resistance, and as a result, high blood pressure and hypertension. And updated guidelines provided the instruction for the correct measurement of blood pressure that identifying three types: is office, home, and ambulatory. For the office blood pressure measurement, it's important to measure after 5 minutes rest, use a validated device, measure blood pressure 3 times in both arms, and assess the heart rate and pulse to verify some arrhythmias, especially atrial fibrillation. Home-based blood pressure measurement is similar to office blood pressure measurement. However, the interpretation of the result is a little bit different. I will talk about that some later. And if we say about the ambulatory blood pressure measurement, it highlights the importance of using a validated blood pressure device, performing frequent measurements throughout the day at night, ensuring that at least 70% of the readings are usable, and maintaining diary to record activities, medication intake, and sleep. It also outlines diagnostic thresholds for hypertension based on 24 hours, daytime and nighttime, and average values. And after the measurement, the diagnosis hypertension is diagnosed when the office blood pressure more than 140. Home blood pressure monitoring is when is more than 135, and ambulatory blood pressure monitoring shows daytime average values more than 135. And long-term high blood pressure leads to damage to organs and systems, particularly to the eyes, brain, large and medium arteries, and the microcirculation, kidney, and the heart. So on this slide, we could see the main diagnostic examinations by organs. If we say about the kidney, we should examine an GFR. If we say about the heart, it's ECG, echo. And if we say about arteries, it's a pulse wave velocity, cardiac CT, and carotid and femoral ultrasound. So, but diagnostic capabilities of myocardial remodeling. If we say about the remodeling, we also always mean about the remodeling of the heart or left ventricle hypertrophy. So this picture shows how the hypertension step by step leads to left ventricle hypertrophy. It's a neurohumoral activity after the cascade mechanism leads to myocyte damage and fibrosis. The mechanical threat after the cascade mechanism leads to impaired coronary reserve, and this is both after the all these conditions lead to left ventricle hypertrophy, and as a result lead to 3 huge complications. The first is arrhythmias, especially atrial fibrillation. The second is heart failure because of decreased ejection fraction associated coronary artery disease due to the impaired coronary reserve. So before the saying about the remodeling of the heart, we should say about the type of remodeling. According to the American Society of Echocardiography, left ventricle geometry is classified based on 2 key parameters. The first is left ventricle mass, adjusted per body size and relative wall thickness. This diagram illustrated 4 types: normal geometry, concentric remodeling, eccentric hypertrophy, and concentric hypertrophy, depending on combination of left ventricle mass and the relative wall thickness. As this is an example. If we say about normal geometry, it's a relative wall thickness is must be less than 0.42, and the left ventricle mass must be more than 115 in male, and less than 115 in male, and less than 95 in female. So after the several years of hypertension existing, concentric remodeling will appear. It means left ventricle wall thickness increasing, normal or decreased left ventricle capacity, and increasing of relative wall thickness. It's the first stage. If the patient will be untreated, it transfers to the concentric hypertrophy. It means increased global left ventricle wall thickness. increased left ventricle mass and increased relative wall thickness. And if we add to this condition an increased left ventricle cavity, increased left ventricle chamber, it's transferred to eccentric hypertrophy. It means increasing end diastolic volume and meaning decreased ejection fraction and chronic heart failure as a result. So, in a summarized echocardiographic signs of left ventricle, the first is thickening of the interventricular septum and the posterior wall of the left ventricle in the diastole equal to 11 millimeters or more. The second, the interventricular septum thickness to posterior wall thickness ratio more than 1, and increase in left ventricle myocardial mass index. There are 3 types: light, moderate, and severe. At this pictures, we can see the increased intraventricular septum thickness. Here is and the posterior wall thickness increasing. These echo signs with 100 accuracy verify remodeling of the left ventricle, but have certain drawbacks. The first is discovered after several years of disorder. It's maybe after the 5, 10, maybe 15 years, and usually irreversible. It has become too important to find an early marker of myocardial remodeling to detect remodeling before the disease progression. It means in the early stages. And this is a consensus recommendations endorsed by the European and American cardiology societies in 2011 and 2015. This emphasizes that speckle tracking echocardiography is recognized by experts as a standard method for the quantitative assessment of myocardial deformation at the preclinical stages. So why is the global longitudinal strain? As I say, it has lots of reasons. The first is the high sensitivity. It detects early myocardial contractility disorders before the ejection fraction decrease. Second, it's a quantitative assessment, allows measuring longitudinal, circular, and radial myocardial deformation. Third, it's not invasive, a safe method that does not require contrast or radiation if we compare with MRI. And objectivity reduces the influence of operator-dependent factors compared to traditional echocardiography. It's almost automatically. And the fifth is a clinical significance used for diagnosis, prognosis, and monitoring of therapy for various cardiac disorders. It not only the arterial hypertension, maybe ischemic heart disease, cardiomyopathy, or sometimes myocarditis. So how does it work? In left ventricle hypertrophy caused by arterial hypertension, maybe ischemic heart disease, longitudinal function of the myocardium is primarily affected, which is reflected in reduced global longitudinal strain values. This allows for the detection of subclinical left ventricle dysfunction before the ejection fraction decreases. And how does it work? Longitudinal shortening covered and just endocardium, and we know that endocardium suffers the first when the cardiovascular disorders will appear. And this is at this screen we can see how the global longitudinal strain is calculated and the degree of the contraction of all the wall. I should say that the normal quantities of a global longitudinal strain is more than -18. There is a -19. It's a normal. So if say about carotid arteries, to detect changes in brachiocephalic arteries, intima media thickness is measured. A thickness exceeding 14 millimeters is present as a plateau, while a thickness greater than 0.8 or 0.9 is considered indicative or vascular wall thickness. At this picture, we can see the plateau with the stenosis approximately 30%, and the wall thickness is approximately 1.7 millimeters. With age, the elasticity of blood vessels decreases and the walls of blood vessels become enlarged, and if at young age 0.9 millimeters can be considered as a sickening. At the age of over 60, this can be considered as a normal. So we should remember about it when we examine the patient, and we should ask the age of patient. Another method is an ECG, and the ECG we can verify just signs of left ventricle hypertrophy. It's tip is waves in V1 and V2, and tall air waves in V5 and V6 leads. And ECG criteria for the ventricle hypertrophy, all of us know about that. It's Sokolov line criterions. That index is most used despite having lowest sensitivity. It has a high specificity, more than 85%. And if we say about the detection of remodeling, the first, it's by echocardiography. It's a classic or 2D spectral tracking. The second, it's a carotid arteries ultrasound examination. And the third is ECG. We can verify a left ventricle hypertrophy signs. If you have some questions, I would like to answer it. Thank you for your attention.
Okay, thank you very much, Andrei. And we can the questions I think will be at the end of the session. And now I will give the chairing to Professor Yi Zhang. Please welcome to present other two speakers.
Okay, thank you, Professor Mirahimov, and I'm happy to join this section. And the third speaker is Professor Liu Jing. He is a very close friend of mine, and he will represent his recent paper named Asia Expert Consensus on Lectural Hypertension Management. I think it's a very interesting topic. Please, Professor Liu.
Thank you, Professor Yi Zhang and Professor Erkin Mirahimov. And dear colleagues from Asia, it's my great pleasure to share my presentation about the Asian Expert Consensus on Nocturnal Hypertension Management. This consensus paper was published this month of Journal of Hypertension, official journal of American Heart Association. This is the first international consensus document on this field. Despite the fact that we have published nocturnal hypertension management experts consensus at the early of this year in the frame of Chinese Hypertension League. But this is still the first time that's agreement on how to manage nocturnal hypertension in the field of Asian population, and it will be of help for hypertension patients to achieve high quality blood pressure control. I'm very glad, and it is also my great honor to collaborate with excellent experts from Asia, Professor Erkin Mirahimov and Professor Jigong Wang as corresponding author, and we also collaborated with other more than 30 leading experts in different fields, such as in the specialty of cardiology, nephrology, and gerontology across China and Asia. And this is a long journey for this consensus final reach to the publication. It is more than 1.5 years, and we initiated during the Asia Pacific Congress of Hypertension in Shanghai in year 2023. And after several rounds of discussion among our internal expert panel, as well as some external experts from across China, we finally reached the consensus paper and submit to hypertension. And this huge work has been published finally. Why we need to such a consensus document? Because we all know that the nocturnal hypertension is very high prevalence in China, in Japan, and the other part of the Asia region. And the epidemiology studies demonstrated that the prevalence of nocturnal hypertension is higher in Asians than the Caucasians. And in recent years, more and more evidence accumulated that demonstrated nocturnal hypertension is more associated with severe target organ damage, as well as cardiovascular morbidity and mortality. It was even so that was independent of daytime or office blood pressure. But in the real world, we can see that nocturnal hypertension is usually under-diagnosed because the ambulatory blood pressure monitoring is not available for every hypertension patients. Even they are referred to the clinical hospital or community medical center. And we can see that in different guidelines that nocturnal hypertension is means elevation of blood pressure level during sleep at night. But usually in European or Chinese hypertension guidelines, they need to blood pressure reach to 120/70 or above to define the nocturnal hypertension. But there is still a special phenotype that we named as isolated nocturnal hypertension. It means blood pressure elevated during night, while it is normal during the daytime. In general, ambulatory blood pressure monitoring during 24 hours is still a gold standard for screening and diagnosis of nocturnal hypertension. But some validated novel cuff-based oscillometric home blood pressure monitoring devices has been approved for sleep or nocturnal blood pressure monitoring. So in the future, we think that some new wearable devices could be provide very promising results for the screening or diagnosis of nocturnal hypertension. In a different study, we can see that the nocturnal hypertension was prevalent in among the Asian populations. In Chinese population study, we can see that nearly half of the participants could be diagnosed with nocturnal hypertension. While in the Osama study or Japanese JAMP study, we can see that the prevalence of nocturnal hypertension varies from nearly 16% to more than 60%. That means that in the Asian population, nocturnal blood pressure elevation should be cause attention, especially for the cardiovascular prevention. And at the same time, that we can see the nocturnal blood pressure is very is varied during different seasons. A Chinese study has demonstrated that the nocturnal blood pressure was the highest in the summer, while lowest in the winter. This also reminds that we should pay more attention for nighttime blood pressure management, especially during the summertime. In the past decades, there is a numerous study focused on elevated nocturnal BP and asymptomatic target organ damage. We can see that from the different studies, the evidence demonstrated that the pulse wave velocity or intima medium thickness of the carotid artery, or even for the myocardial per se, that increased left ventricular myocardium index was also associated with elevated nocturnal blood pressure. And with the elevation of nocturnal blood pressure, there is an increased incidence of cardiovascular disease, as well as heart failure or stroke. At the same time, nocturnal BP also have effects on the renal function and is associated with chronic kidney failure. Clinically, we should pay more attention to some special population for the screening of nocturnal hypertension. Asian population is more prone to nocturnal hypertension because we are generally have a more salt intake and a high salt sensitivity. At the same time, we can see that more and more people become overweight or obese, and in the population with chronic kidney disease or those with diabetes, there is a high prevalence of nocturnal hypertension during this special population. For the people with sleep disorders, include those with insomnia or with obstructive sleep apnea, and those with elderly patients suffer from Parkinson's disease. There is still a high prevalence of nocturnal hypertension in this population. But for clinical doctors, we are more interested in how to treat to the nocturnal hypertension during the clinical practice. In general, we reach agreement that the nocturnal BP should be should be controlled below 120/70, and some general strategies such as lifestyle changes, especially focus on salt intake restriction, more exercise, and other lifestyle modifications, including the exercise or weight control, should be emphasized in the treatment of nocturnal hypertension. And for some patients, we can see, despite that they are receive blood pressure lowering medications, but they are inappropriately use some short-acting antihypertensive medications. So this should be switched to a long-term, long-action blood pressure lowering medications. There is still some disposing factors should be removed, such as sleep late at night, or some people are have the habit of take more salt or salted food, and they should be educated to make some modifications on their lifestyle or habits. At the same time, that primary disease, such as OSAS, should also be treated accordingly to maximally to reduce the influence on nocturnal BP. For the treatment of nocturnal hypertension, we recommended that long-acting blood pressure-lowering medications should be used preferentially in the treatment of nocturnal hypertension. 5 classes of BP lowering medications, such as diuretics, ACE inhibitor, ARBs, beta blockers, or CCBs, in general could be initial choice. But for some patients with sleep disorders, that we need to try best to avoid use diuretics during the nighttime or before sleep. Long half-life agents are recommended. Some special formulations, such as control release drugs, could also be used to guarantee the 24-hour blood pressure control. And in practice, that more and more people need to use combination therapy to reach the blood pressure at goal. We also find that some innovative medications have the property or advantage on nocturnal BP reduction, such as alisatan isoproxil. This is a new non-peptide ARBs invented by Chinese experts and now has been launched in China or even for other countries. From the clinical studies, we find that they have the advantages on the nocturnal blood pressure reduction. The BP reduction was even more pronounced during night than the daytime. Sacubitril valsartan or sacubitril alisatan also available in China, in Japan or other countries. They also have the advantages on the nocturnal BP reduction. Endothelin receptor ETA, ETB dual antagonist, and also such as some newly selective MRA, isacsarenone, and SGLT2 inhibitors also demonstrated the evidence on nocturnal BP reduction. These drugs could be used for nocturnal hypertension treatment. Finally, I want to mention some non-pharmacological treatment of nocturnal hypertension. One is renal denervation. This is approved device-based therapy for resistant hypertension. And when we learn about some result published paper, we can see that nocturnal BP also could be effectively reduced by renal denervation. And for patients with nocturnal hypertension and OSAS, continuous positive airway pressure, CPAP, may be an effective treatment choice to reduce nocturnal blood pressure. In this consensus paper, we also describe some challenges in the nocturnal hypertension management. We need to develop more and more home blood pressure monitoring devices that could be used during the nighttime. And at the same time, we should also monitoring the sleep quality simultaneously. And for the clinical management of nocturnal hypertension, we need to identify some high-risk patients that needed to be benefited with a strict nocturnal BP control. And despite the evidence is absent, especially for the outcome study, some pathophysiological-based treatment strategies are also very practical and should be more investigated in the near future. In this Asian expert consensus paper on nocturnal hypertension management, we finally reached several agreement on the definition of nocturnal BP, who should be screened, and how to measure the nocturnal BP. The 24-hour blood pressure, ambulatory blood pressure monitoring is still the standard and commonly used method, but in the future, some validated home blood pressure nighttime monitoring devices also can be used, and very smart wearable devices are promising in this field. For the blood pressure target, we recommended in general nighttime blood pressure should be controlled below 120 over 70 millimeter of mercury, and low sodium intake, sleep improvement, and weight control exercise are very harmful and useful for nighttime blood pressure control. For the treatment of nocturnal hypertension, we emphasize the use of long-acting antihypertensive medications in full dose or in combination with other medications, and agents with nocturnal BP reduction property are preferred. Some devices-based therapies such as renal denervation or CPAP can be used in appropriate patients. This is my presentation. Thank you. Thank you very much.
Thank you, Professor Liu, and congratulations on your recent publication. And I think it's a very interesting topic and well organized and fruitful information. And I think in the future, we will have a lot of work to do in this field. And I hope that we can read more papers and stories from you. Thank you very much for your sharing. And so we still have some time later for the discussion at the end of this section, maybe. And so we move to the fourth speaker, the last speaker, Professor Chen Yiling, also from China, and she will give us a topic named cardiac structure and functioning in primary aldosteronism. Welcome. You can start, Professor Chen.
Okay, dear professors and colleagues, my name is Chen Yiling from the Shanghai Institute of Hypertension. It's my great honor to give this presentation. Today, I would like to share some imaging studies we did in primary aldosteronism using novel echocardiographic technique. My topic is cardiac structure and function in primary aldosteronism. As we all know, primary aldosteronism is one of the most common secondary hypertension, with a prevalence from 5% to 15% in hypertensive patients. It is characterized by the excessive production of aldosterone in adrenal glands and inhibition of renin. And in early animal studies, we can see that aldosterone was shown to induce myocardial fibrosis and scarring in both left and right heart, as well as aortic and pulmonary artery. The total collagen volume fraction and interstitial collagen volume fraction, the two fibrosis biomarkers for the left and right ventricles, was significantly higher in aldosterone infusion rat models than the control group. And in clinical studies, left ventricular hypertrophy and diastolic dysfunction was shown in primary aldosteronism patients compared with primary hypertensive patients. However, systolic functional indices such as left ventricular ejection fraction remained similar between groups, possibly because the conventional echocardiography could not fully evaluate cardiac function, especially in early cardiac damage period. And speckle tracking echocardiography is a new technique to evaluate cardiac function. The main principle is to calculate strain, a parameter of cardiac deformation and function, by tracking a bright speckle frame by frame. Positive value means myocardial shortening or thinning. Negative value means myocardial lengthening or thickening. The advantage of the strain technique was to evaluate early cardiac functional changes. Left ventricular pressure strain loop is another recent novel technique to quantify cardiac function based on speckle tracking echocardiography and cardiac afterload, the blood pressure. The myocardial work curve was achieved in combination of the standardized pressure curve obtained through animal and clinical studies and segmental strain by speckle tracking echocardiography, which we can see in the left figure. And based on previous studies, myocardial work indices from left ventricular pressure strain loop included GWI, Global Myocardial Work Index, defined as total work within the area of the left ventricular pressure strain loop, GCW, Global Constructive Myocardial Work, defined as the work with myocardial shortening during systole and lengthening during isovolumic relaxation, GWW, the Global Wasted Myocardial Work, defined as myocardial lengthening during systole and shortening during isovolumic relaxation, and GWE, Global Myocardial Work Efficiency, defined as global constructive work divided by global constructive work and wasted work. Using these techniques, we could quantify cardiac systolic and diastolic function in all cardiac chambers as long as the echocardiographic images are satisfied. The global longitudinal strain especially is recommended in the evaluation of left ventricular systolic function in the American and European guidelines. The myocardial work indices, on the other hand, could provide additional information on cardiac function as it incorporates measurements of myocardial deformation and left ventricular pressure. It might give a better understanding of cardiac physiological changes under various loading conditions than longitudinal strains. So in our study, we applied these new echocardiographic techniques to assess cardiac structure and function in patients with primary aldosteronism. First, we will discuss on left ventricle and atria. Like previous studies with conventional echocardiography, we also found left ventricular hypertrophy with significantly higher interventricular septal wall, posterior wall thickness, and left ventricular mass index in primary aldosteronism patients, as well as significantly decreased diastolic function compared with primary hypertensive patients. And with subtype aldosterone-producing adenoma, the most impaired. With speckle tracking echocardiography, significantly decreased global longitudinal strain was shown in primary aldosteronism patients, with subtype aldosterone-producing adenoma most aggravated, although both primary hypertensive and primary aldosteronism patients had similar and normal conventional systolic functions, such as left ventricular ejection fraction. And the layer-specific strains, including endo, mid, and epi-longitudinal strains, were all significantly correlated with the level of aldosterone when analyzing in all patients. In left atrial structural and functional analysis, we also found significantly larger left atrial volume and decreased left atrial ejection fraction in primary aldosteronism patients. The left atrial string during reservoir conduit and contraction period was all significantly lower in primary aldosteronism patients, with most impaired in aldosterone-producing adenoma patients. Also, in correlation analysis, the decrease of left atrial strings during reservoir conduit and contraction period were all significantly correlated with the level of plasma, both plasma and urinary aldosterone. So in the first section, we have observed the functional changes in left heart. Previous animal studies have shown cardiofibrosis in both right and left ventricles. So what's the effect of aldosterone on right heart in clinical study? So in the next section, we study the changes in right ventricles and atria. In previous clinical study on pulmonary hypertension, aldosterone was found to be highly correlated with pulmonary vascular resistance, transpulmonary gradient, and cardiac output in patients with pulmonary hypertension, but its correlation with right heart in early stage remained unclear, so we enrolled primary aldosteronism patients to investigate the correlation between aldosterone and right cardiac structure and function. We enrolled 50 primary hypertensive patients and 51 primary aldosteronism patients. The demographic characteristics remained similar between groups, except RAS indices. In related to right cardiac echocardiographic data, almost all right cardiac dimensional parameters were significantly larger in primary aldosteronism patients. Right ventricular free wall thickness and the diastolic function measured as E versus E prime were both significantly higher. Besides, the primary aldosteronism patients had significantly lower tapes, the systolic excursion of tricuspid annula, higher pulse, systolic pulmonary arterial pressure, and RMP, the right ventricular tape index, compared with primary hypertensive patients. On right ventricular strain analysis, both right ventricular four-chamber longitudinal strain and right ventricular free wall longitudinal strain was significantly lower in primary aldosteronism patients than primary hypertensive patients. Besides, the two right ventricular longitudinal strain indices were both significantly correlated with plasma aldosterone and 24-hour urinary aldosterone. With backhoe tracking echocardiography, we could observe the early functional changes in both left and right heart. In the third section, we investigated its mechanism, cardiofibrosis in primary aldosteronism, using left ventricular pressure strain loop and with cardiomagnetic resonance as the gold standard. According to current references, there are three types of cardiofibrosis. Diffuse interstitial fibrosis, usually seen in hypertension, diabetes, and aging. Infiltrative interstitial fibrosis, usually seen in cardiac amyloidosis and Fabry disease. And focal replacement fibrosis, usually seen in acute and chronic myocardial ischemia, chronic nephritis, and myocarditis. The first two types of fibrosis could transfer to the third type. Cardiac magnetic resonance could evaluate these types of cardiofibrosis non-invasively. Focal replacement fibrosis could be indicated by late gadolinium enhancement, LGE, and diffuse interstitial fibrosis could be assessed by extracellular volume, ECV, with T1 mapping. So with cardiac magnetic resonance as the gold standard, we investigated the diagnostic value of the left ventricular pressure strain loop based on speckle tracking echocardiography for myocardial fibrosis in patients with primary aldosteronism. We have enrolled 48 primary aldosteronism patients, 30 with late gadolinium enhancement LGE with a prevalence of 62.5%. On demographic and clinical characteristics, patients with LGE had significantly longer duration of hypertension, and heart failure biomarker NT-proBNP was significantly higher in LGE group. On conventional echocardiography, patients with LGE had significantly higher interventricular septal wall and posterior wall thickness and left ventricular mass index. On string echocardiography, these two groups were comparable in global longitudinal string, myocardial work index, and myocardial work constructive work. Both groups were also comparable in T1 mapping indices, including ECV. However, patients with LGE had significantly increased global wasted work and decreased global myocardial work efficiency. In univariate logistic analysis, LGE was significantly correlated with the duration of hypertension, long transformed NT-proBNP, left ventricular mass index, global myocardial wasted work, and the global myocardial work efficiency. And after stepwise multivariate analysis with age and sex as fixed factor, the global myocardial work efficiency was still significantly correlated with LGE. ROC analysis showed that a global myocardial work efficiency less than 92% had a sensitivity and specificity of 76% and 83% respectively for LGE, with the area under curve 0.85. In addition, the diffuse interstitial fibrosis parameter ECV was significantly correlated with the long transformed NT-proBNP and long transformed aldosterone-renin ratio ARR. In cross-sectional studies, we have confirmed the cardiac structural and functional changes with aldosterone. What's the result after treatment? So we perform a prospective observational study in the fourth section to compare effects of surgery and drug treatment on the cardiac structure and function, also assessed by the string echocardiography. According to guideline, both surgical and medical treatment are recommended to primary aldosteronism patients, with adrenalectomy to those with unilateral secretion of aldosterone and mineralocorticoid receptor antagonist to those with bilateral section. Previous studies have shown that both surgical and drug treatment could effectively lower left ventricular mass index and control blood pressure, but the impact on cardiac function between treatments still needs further investigation. So in our study, we enrolled 67 patients with primary aldosteronism, 39 with surgery, and 28 with drug treatment during 6 months of follow-up. The two groups were comparable at baseline except plasma renin activity and 24-hour urinary aldosterone excretion. After 6 months of follow-up, all patients achieved normalization of serum potassium, but the changes were more significant in surgery group than drug treatment group. Plasma aldosterone concentration was significantly decreased and plasma renin activity was significantly increased in both groups, also with surgery group more significant than drug treatment group. Although blood pressure in the two groups decreased to similar level, as well as left ventricular mass index and left atrial volume index, the changes in left ventricular end distal diameter, global longitudinal strain, global wasted work, and global myocardial work efficiency were more significant in surgery group than drug treatment group. In detail, on the left figure of blood pressure, systolic blood pressure in surgery and drug treatment group decreased significantly at 3 months compared with baseline, and both groups decreased to a similar level at 6 months. Diastolic blood pressure was similar at 3 months, at 6 months compared with baseline. The right 4 panels were changes on cardiac structure and function. Both left atrial volume index and left ventricular mass index decreased significantly at 3 months of follow-up in both surgery and the drug treatment groups, with surgery group occurred earlier at 3 months of follow-up. But global longitudinal strain and myocardial work efficiency was significantly improved only in surgery group instead of drug treatment group. And in addition, we also performed correlation analysis. The changes in global wasted work at 6 months of follow-up was significantly correlated with that in 24-hour urinary aldosterone in the drug treatment group and the two groups combined. So in total conclusion, first, primary aldosteronism showed cardiac dysfunction in both left and right heart, probably because of hypersecretion of aldosterone. Second, primary aldosteronism patients had both focal replacement and diffuse interstitial fibrosis and were both correlated with the heart failure biomarker NT-proBNP. Cardiac dyssynchrony represented by global myocardial work efficiency was associated with focal replacement fibrosis, and diffuse interstitial fibrosis was related to the abnormalities in aldosterone and renin. Third, in spite of similar blood pressure control, unilateral adrenalectomy showed early improvement in cardiac function, probably because of sufficient inhibition of aldosterone and other therapeutic effects. Thank you very much.
Okay, thank you, Professor Chen. Thank you for sharing us this topic. And I think it is very impressive. And according to a lecture that we all can get the information that the patients with PA suffered from the more severe cardiac structure and the functional change. And maybe the surgery is preferred in these patients. Thank you for sharing. Okay, maybe that we can also ask Professor Mirahimov. You can start the discussion section, please.
Yes, thank you. Thank you for giving me. So our floor is open for discussion. Just for starting, I want to ask about renal denervation. I know that in our country, renal denervation is not widely used. It's because due to some lack of experience, some lack of budget finance. I would like to know about the renal denervation in, for example, in Uzbekistan or in China. How often do you use renal denervation? Maybe some guys from China can, and Andrei can say how many patients.
Yeah, thank you for the question. It's really renal denervation. It's our country is similar to Kyrgyzstan, and renal denervation is not commonly used. It's a true rare. I think in last maybe 10 or 15 years, I can count just maybe 3 or 4 these procedures.
The same as in Kyrgyzstan, we have maybe 3 or 5 just renal denervation only procedures, renal denervation. Also, I would like to ask about maybe 10 years ago or 15 years ago, the baroreflex stimulation was popular. What about now? Alina, can you tell about baroreflex stimulation? Is no more used?
So nowadays, baroreflex stimulation is not confirmed by the recent clinical guidelines, and unlike previous 2 decades before, nowadays it's not recommended and not safety due to lack of evidence. And in Kyrgyzstan, we do not use baroreflex stimulation.
Also, it was interesting things about structure, about remodeling of left and right heart. So, but I know that, for example, strain echo or speckle echo, it's time consuming and human resource consuming. Are there any criteria for recommendation who can undergo this speckle echo or strain echo? For example, maybe patient with severe hypertension or patients with left ventricle hypertrophy, or you can use speckle echo or strain echo in earlier stages of arterial hypertension when remodeling is not seen. What can you say about this question for Professor Chen Yilin and also for Andre Kim? Any criteria? Because I don't know, because standard echo, we use only look at cavity size and ejection fraction. But if you use for strain echo and speckle echo, it prolongs the time of investigation. So what is the criteria who must be undergo this echo procedures like speckle or strain? Okay, that's a question for Professor Chen Yilin and Andre Kim.
And
Okay, thank you, Professor Mirikov. It's a very good question. Currently, the cutoff value of the speckle tracking echocardiography, I think, might be varied, but especially in global longitudinal strain, most experts agree that the normal value was above 18 or 20%. And lower than 16% might indicate there are some cardiac damage for these patients. And I think speckle tracking echo and the second question, what kind of people could choose the speckle tracking echocardiography? I think we can use speckle tracking echocardiography in the general population as long as the cardiac echocardiography images are satisfied. But the major problem is sometimes in our country, in China, there are a lot of patients in our hospitals, and we usually and the strain analysis usually needs offline analysis. And but in most in these peoples who might be there might be some cardiac image damages. You might if there is a population, you might think there might exist the cardiac damage. You can use speckle tracking echocardiography to eliminate if the strain value, especially the longitudinal strain value, was above 20%. And I think the disease, the speckle tracking echocardiography is applied in several diseases, not only hypertension, but also like the tumor, cardiac tumor diseases. It's a very recent hot topic in worldwide, and I think that's my answers. And maybe Professor Andrew Reno Aliva has some supplements.
it's absolutely right that Professor Chen Yilin said. But in our country, in Uzbekistan, we have some different added criteria, if I can say that. First, we record all the echo examines because we have a TomTech application, and via TomTech we can calculate it after the examination of the patient. It may be in the evening, in the morning, after maybe in the free time. So it is comfortable for us, and the criteria. So we usually use a speckle tracking examination to the patients with a resistant hypertension, especially in young patients with arterial hypertension, maybe more than 2 or 3 years, to identify the early myocardial remodeling, as Professor Mirakim said. He was right. So it's early prognostic markers for us to prevent chronic heart failure in some young patients. And the second, we do not use speckle tracking in patients with ischemic heart disease, because the ischemic heart disease leads to decreasing of global lung strain as usual. So it's not necessarily. So it's if we say about the criteria, it is arterial hypertension, resistant arterial hypertension, hypertension in young persons, and the hypertension is length of their diseases less than 5 years. Because of the 5 years, the remodeling starts.
Yes, if I can come back to the questions. The first question about renal denervation in China. And actually in China that we try several procedures in mainland, and also we also have 3 domestic renal denervation device has been validated in China. There are 3 RCTs published in Circulation and eClinical Medicine and some journals. So now that we have 4 types of the renal denervation device, and in some province in China, like in Shanghai or in Wuhan, several provinces, the medical insurance can cover the cost of the renal denervation. So more people will come to accept this procedure. But the biggest problem, I think we all know this quite well, is that we do not have the good criteria to choose the responders of the renal denervation, because it's reported that about 1/3 of the patients do not respond well to the procedure. So it's a big problem, actually. And now in China, that in several centers, like in Shanghai, Professor Chen stayed in Shanghai Institute of Hypertension. I started there with Professor Ji Guangwang, and in their center, the biggest center maybe in China, they have like 1, 2, 3 maybe procedures per week, I think. So now we accumulate the experiences, and I also have some idea to start procedures, operators group, like a little club, that we all every month that we do renal denervation, and we can share some cases, can to communicate and to study, and because in this field I think that a lot of issues is under investigating. So we need to better understand it, to choose the right person and do the right procedure, and then to manage hypertension after the procedure. So a lot of things need to do. So I think that's the situation. Okay, thank you.
Also, I would like to maybe not to ask, but just to maybe give a recommendation concerning the remodeling of heart during in case of arterial hypertension. I think there is differences between Asian countries and Western countries in developing of concentric or eccentric hypertrophy, and the different data on speckle echo or like strain echo. So it's my recommendation to have to write maybe like consensus, as Professor Jingli Liu done for nocturnal hypertension, to write like consensus paper on like remodeling of the heart during the hypertension, about data of speckle and strain echo, the differences between Asian countries and between Western countries, for example, in the United States or Europe. I think there's will be very interested consensus on nocturnal hypertension. Maybe Professor Chen Yilin from Shanghai and from Uzbekistan can just start this consensus with Jiguang Wang professor, and is very famous in this field. Just as my recommendation. So we need to have more consensus coming from Asian Heart Society, from Asian countries regarding every topics in cardiology.
Yeah, I think it's a very good suggestions that we can talk it later, maybe with Professor Chen and also with Professor Jiguang Wang, and we can come back to you later. Okay,
yes,
thank you. Very interesting.
I will happy to participate.
Okay, great.
I think it's time to finish. So I would like to thank all attendees, all speakers, my co-chair, and hope to see you next future. And if someone from the speakers can say just greetings or willings, you can say we have 1 minute left.
Professor Mirakimov,
Maybe
I
you,
absolutely agree.
Yes, I think that it's a very interesting section, and that we share a lot of new topics and ideas, and we have the same situation about renal denervation. It's a big change in the hypertension field, and also the nocturnal hypertension. It's a very fresh topic, and I think in future we can combine together and have more work to do. Thank you. Yes, I enjoy it very much. Thank you.
Okay, thank you very much for all attendees, and hope to see you in closest time. Thank you. Bye-bye.
Thank you. Okay.
Thank you.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.